think we can get started if that's okay with everyone. Welcome, I'm Vanya Hanif. I'm the Chief Executive of Association of Mental Health Providers. I'm also joined from the association by my colleagues Victoria and Ella, who are going to be in the Q&A to support the event. So welcome to today's webinar on the implementation of the Mental Health Act and the Right Care, Right Person. Today's event is being hosted by the Association of Mental Health Providers and the Care Provider Alliance. The association is the national representative organisation, the leading voice of the mental health charity sector. We've got a membership of over 300 mental health charities, providing over 300 services to over 8 million people across England and Wales. I'm joined today by my co-chair, Steve Gilbert, a former trustee of the association, also was the vice chair with the independent review for the independent review of the Mental Health Act, and I'll let him say hello and introduce himself.
Hi, yeah, so I was one of the vice chairs for the Mental Health Act review. I have a very long personal mental health experience. I'm dual ethnicity. On the black side of my family, there's a lot of mental illness, and that's involved contact with a lot of emergency services, including the police. And yeah, as a former trustee of the Association of Mental Health Providers, I'm really looking forward to supporting this event today.
Thanks, Steve. So today we'll be discussing the implementation of the Mental Health Act 2025. It does represent one of the most significant reforms to mental health legislation in a generation, with a strengthened emphasis on rights, autonomy, racial equity, and least restrictive care. The Act creates both opportunities as well as challenges for mental health systems across England. We'll also briefly be touching on the implementation of our CRP, the Right Care, Right Person, more so probably in kind of the discussion, and that in itself continues to reshape how responsibility for people in mental health crisis is distributed across the NHS, local authorities, VCSE organisations, as well as the police. We've got a great lineup of speakers today, and we're welcoming to discuss these issues Matthew Siddons and Samantha Monday from Department of Health and Social Care, and they'll be focusing on the implications of the Mental Health Act, looking at the policy context. Please do keep an eye on kind of like the Q&A section and do put in your questions as we go along, and we'll come back to these within the discussion.
Thank you very much. So hello everyone, I'm Matt Siddons. I'm head of the Mental Health Act Operations and Implementation team in Department of Health and Social Care. And Sam is in my team who will talk later. Sam, do you want to briefly introduce yourself?
Yeah, so I'm Sam. I work in the Department of Health and Social Care, and I work in Matt's team on Mental Health Act implementation. And previously, I worked in the bill team on the mental health bill.
So we're going to give a short presentation today that will briefly outline the changes that are coming in as part of the Mental Health Act 2025, and then our plans for implementation and how that will be staggered over time. So if you could go to the next slide, please. So a very brief overview of the history. This all started with the independent review, which was in 2017 and 2018, which Steve mentioned he was one of the co-chairs of. That led to a number of recommendations, which were almost all accepted in the white paper, which was published in 2021. We drafted a bill in 2022, which went through a process of pre-legislative scrutiny, and then it eventually went to Parliament at the start of 2024, and it passed on 18th December 2025. So this is the new legislation that amends the previous Mental Health Act from 1983. It's not entirely new legislation, it's mostly amending and changing the processes that already exist. If we could go to the next slide, please. So the aim of the new act is to improve care across the pathway from pre-detention when people are approaching crisis, through the crisis itself, decisions around detention, what treatment people receive during their inpatient care, and then the process of discharge, any aftercare, and community treatment orders as well. There are 4 principles that underpin our reforms. Firstly, improving choice and autonomy so that service users' views and choices are respected much more than they have been. The principle of least restriction, so ensuring that the powers are only used in the least restrictive way possible. A real focus on therapeutic benefit, so that we're ensuring patients are supported to get better, not that they are just detained and left in inpatient settings. And treating the person as an individual, so ensuring patients are viewed and treated based on the risks and the needs that they present with, and not based on any prejudgment about their level of risk or the context in which they've come into the service. Next slide, please. So in terms of choice and autonomy, I'm going to briefly run through the key changes that are part of the legislation under each of these kind of broad headings. So firstly, patients will be able to write advanced choice documents when they're well before they're detained, setting out wishes and preferences in case they are detained in the future. This is already possible. People do already write advanced choice documents, but the legislation gives them a greater statutory footing, and some of the later reforms will make sure that people have to go and consult these documents when they're making care and treatment plans. Secondly, patients will be able to choose their nominated person. So at the moment, you have a nearest relative when detained, which is preordained by the legislation, but that often doesn't suit many people's reality and the experience of their own family life. So we're giving people the right to choose their nominated person who has important rights under the Act to represent for that person and do things such as request ultimately their release from the Act, and they have powers to do that. More people will have access to independent mental health advocates. Currently, this is provided on an opt-in basis for formal inpatients. We'll be expanding it so it becomes opt-out. People will get an independent mental health advocate unless they choose not to have one. And secondly, we'll be extending the coverage so that people who are informal patients, so people who are inpatients but not detained under the Mental Health Act, will also have access to IMHAs. And we'll be introducing statutory care and treatment plans. So this is putting existing good practice about care and treatment planning onto a statutory footing. Next slide, please. In terms of least restriction and therapeutic benefit, so the criteria for detention are going to be amended so that the focus is on receiving therapeutic benefit and making sure that there is a risk of serious harm to yourself or others. This is one of the recommendations that came out of the independent review, and the thing that led to that independent review being inappropriate use of detention, overuse of detention, and also racial disparities in the use of detention. So we want to make sure that when we're explaining what that decision-making process is and the criteria for that decision, that all of these different aspects are considered. One of the most significant changes will be that people with learning disability and autistic people without a co-occurring mental health condition will no longer be made subject to longer term detention under what's known as Section 3. The point of the Mental Health Act is that it is to detain people so that they can be treated, so that they can improve and get better. And the long-term detention of people with learning disability and autism is no longer going to be possible once the reforms are fully implemented. To say that will take a long time to implement because it requires a significant expansion in community services and services that both prevent people going into crisis and needing detention, but also supporting people to be discharged from inpatient settings. Thirdly on here, detention decisions and reasons for compulsory treatment must be recorded in your care plan, and the care will have greater oversight from second opinion appointed doctors, so that there are more opportunities to review the care plans that are in place, and making sure that they are focused on therapeutic benefit for those that are detained. Fourthly, you'll have greater access to the first tier mental health tribunal. So currently people have a right to access the tribunal after 6 months, 1 year, and then 3 years, we're going to increase the frequency of that so that people will be referred every year to stop long-term detention that leads to people basically not having the ability to review their detention for a very long period of time. And finally, on this slide, additional safeguards to ensure that discharge is safe and well planned, which includes the requirement for responsible clinicians to consult community clinicians when planning community treatment orders. This is to ensure that community treatment orders are appropriate. So to ensure that they are used only when necessary, but also to understand the risks in the community and that they are used when they are needed. Next slide, please. And there will be changes related to people who are under the Mental Health Act as part of the criminal justice system as well. So we're speeding up transfers between prison to hospital when this is needed. And the statutory target will be a 28-day transfer period. Secondly, police stations and prisons will no longer be used as places of safety under the Act. And thirdly, this has already come into effect. There is a new supervised discharge provision, which means restricted patients who currently cannot be discharged into the community with a restriction on their liberty will now be able to do so. This is a relatively small cohort. There's only about 20 people currently who are in this situation, but this basically allows people to be discharged following what was known as the judgment. So that's already happened. We're monitoring how that has an impact in reality, and we'll be able to say more about that when we update Parliament later. We're committed to doing a written ministerial statement in a year's time that will set out the progress that has been made and the plan for the future. Next slide, please. I think Sam is going to pick up now and talk about the next steps in terms of the implementation of these reforms.
Thank you. So yeah, moving on to sort of like implementation of these reforms, as Matt said, it's a long, there's sort of a long time interval implementation, so some reforms will take a while to switch on. So we estimate that full implementation will take around 10 years, but we're taking a phased approach to implementation so that people don't have to wait 10 years for all the reforms and to like have the benefits of the reforms. So the first reforms came in February, on the 18th of February, and that's the supervised discharge reforms that Matt spoke about just now. And then we've also committed to switch on some of the reforms to prison transfers by December 2027, so 2 years from royal assent. The first major set of reforms we are planning to come in 2028-29. So these are reforms that change sort of processes and decision making, but don't come at like a huge additional burden on the workforce. So this includes reforms such as principles, the detention criteria changes, not including the Section 3 changes for people with a learning disability and autistic people, the nominated person provisions replacing nearest relative, and yeah, other sorts of reforms. We've not released a full list of what reforms will be in phase 1, as we're still working through this, but we'll be able to provide sort of more information in due course. And then later reforms that sort of will take longer to switch on due to sort of additional funding, workforce expansion, development of community infrastructure include the changes to Section 3 detention criteria for people with learning disability and autistic people, the increased frequency of mental health tribunals, the new duties on advanced choice documents, statutory care and treatment plans, and the removal of police stations as places of safety. So this is just mapping out sort of at a high level what the different phases of implementation are, and we sort of are calling that first major set of reforms in 2028-29 phase 1. And our priority is sort of implementing phase 1 at the moment. So the next slide, if we can move on to that, please. Yeah, this sets out our timeline to phase 1. So in order to switch on phase one, we need to update the code of practice to reflect the new legislation. So that's our priority for this year, is working to update and draft the revised code, and we'll be engaging as we do this, and different types of progressing at different speeds. And alongside this, we'll also be developing the required secondary legislation for phase one. We will then go to public consultation on the draft code in early 2027, and we'll then also need to train the workforce on the draft code, the reforms, and sort of the new regulations before we're able to commence in 2028, 2029, which is when we'll also be when the new code will come into force, and the required secondary legislation for phase one. We will need to make further updates to the code when we commence later reforms, but we are sort of updating as much of the code as possible for phase one, and then we'll need to publish later updates when we commence the later legislation, so that the code is aligned to the current law. If we move to the next slide, please. Thank you. So this just talks a bit more about our approach to updating the code of practice. So there's sort of 4 main different groups of changes that we'll be doing. So firstly, we need to update the code to reflect the new legislation. We'll need new guidance relating to those new powers and duties. We also want to do a bit of a thematic review of the code, so taking on some of the themes that emerged from the independent review. For example, we need to embed the new principles throughout the code, and it will also be an opportunity to consider sort of things, make more consideration to sort of things like racial disparities and how the code applies to specific cohorts such as children and young people. There's areas of the code that are just out of date that we want to sort of take the opportunity to update to make sure that it's reflective of current sort of policies. There's also some non-legislative changes, so we've committed to sort of in the white paper that came off the back of the independent review and parliamentary debates and sort of other engagement, so we need to make those changes. And this is also just an opportunity to make wider updates to the code, so where things just don't make sense, this is a big opportunity to update. So we're really, really keen to hear from sort of frontline staff, people that use the code, and sort of, other groups on where there might be opportunities to make changes throughout the process. The next slide talks a bit just about governance and engagement for the implementation programme, but also for the code of practice specifically. So we've set up an implementation board, which is a sort of senior officials across government, so other government departments, the department, and arm's length bodies to sort of monitor progress on implementing the reforms. So the code of practice explicitly will be setting up an expert reference group to bring together sort of key stakeholders, which will include sort of professionals under the Act and people with lived experience. We're then going to have sort of different topic groups set up for different policy areas across the reforms. So the topic working groups, we're setting up lived experience groups as well. And then we've committed to a nominated person, children and young people expert task force. So we'll also be setting up a group specifically to discuss the application of nominated person to children and young people, to make sure that there's guidance in the code on that to reflect views. And so that's all the governance. And I think the next slide just talks, so we also committed in Parliament to a consultation into the sort of operation of sections 135, 136 emergency powers. So the powers for sort of the police to detain people under the Act, and we've committed to exploring the different powers sort of available to different professionals in different situations and settings. We're still sort of working to define the scope of the consultation, and we'll work closely with the police and health and care representative groups and people with lived experience to define the scope of this consultation. But we believe that this is the right approach, and this responds to sort of conversations in the parliamentary debates on these issues. I think that's everything that I wanted to say.
So over to you as the people that are part of our webinar today, and we've got a couple of questions. So I'm just going to roll back to the first set of questions, which are relate to our first presentation, and that was a presentation by Matt and Samantha. So the first question is, are there any restrictions on who the nominated person can be?
Thanks for the question. So there are some limited ones in terms of age. Under 16s, the nominated person has to be over 18, and otherwise I think it's over 16. This will kind of be set out in the code itself. The other part of this is about the appropriateness of the nominated person. So that has to be witnessed by somebody who will sign them off, and there are rights to either not approve or remove the nominated person if they're seen to either not be acting in the patient's interests or potentially be a risk to the patient. So there are safeguards there, but it's not preemptive blanket restriction. And nearest relative is very much like, this is the order that things have to happen. Nominated person gives a lot more autonomy to the patient.
Yeah, and I think, in lots of cases that as it is in the hierarchy, it will probably look something like that. But I think in kind of my case, I'm unmarried. My father, I think, would still technically be the person who has that legal right. He's my chief abuser. So again, I'm very kind of supportive of this. But like you said, those safeguards are in place. And again, really kind of putting the patient's needs at the heart of that. So it's going to be interesting to see how that develops. And I think it's going to be an interesting challenge for, certainly the health and also this will touch upon the social care sector around engaging with something that is less prescriptive. While we've still got you here, Matt, and you're on screen, I'll bring up our next question, which I've got. I could also jump in and help you with. So I'm ACDs. I'm been part of work for the last 5 years with South London and Maudsley, and 2 research programs to develop our thinking around advanced choice documents. Matt mentioned, that they are already kind of in existence in some forms. This is quite a move forward in the parts of it that will have legal standing to them, but I think also part of the real challenge is that everyone who is eligible, and at SLAM at the moment, they have decided to roll this out even before it was announced in the Act, that anybody who has previously been detained will be eligible for one. So we're raising the expectation. So we're raising the expectation around being able to make one, and then that naturally raises the expectation that there will be followed. So there's lots of challenges around implementation on this. As for the question that has been posed, it says, who decides? How is it decided when someone is well? Is it assumed that if someone is not detained, then they are well?
So for the advanced choice document, the starting point is a presumption of capacity. The reason that that's the case is because that's the presumption under the Mental Capacity Act. And this is advanced decision or advanced statement. We're kind of mirroring the position of the Mental Capacity Act. So there are processes later on where the ACD can be overruled. SOADs have duties to be involved in those decisions. So it's not as easy as just disregarding it. So if there are concerns about capacity, they can be overruled. But the presumption is that the person has capacity at the point they make the advanced choice.
Yeah, I think the other part of my understanding as well is we're trying to understand at what point is the best time range for someone to be offered that. And again, that's something that we're kind of learning through experience. It won't be that, the week after you come out that, you should complete it. I think we are trying to understand that range. And again, health systems like things that are quite regular, and this, has a bit more flexibility to it. I think the key thing being that not only the person is deemed to have capacity, but I think as importantly, that they've been able to process their experience of being detained and to have a good understanding of what might help. So it's going to be, again, kind of interesting, the flexibility there. For some people, that might be, quite soon after they've been detained. For other people, it might be longer.
And just on that, Steve, the legislation itself is relatively permissive. There are lots of different versions of what an advanced choice document could look like, and we're not requiring a single statutory form or template to be filled out. The work that you've been doing with SLAM is one really good example. There's other work that's been going on by advancedchoice.org and lots of different organisations. All of these versions of an advanced choice document will be allowed under the legislation. And really what we want to do is use the code to set out the principles of how this is used, but not specify the precise process, because different systems are doing different things and they all seem to be working really well.
Yeah, and it's a really, again, it's a really interesting challenge. So yeah, and I think again, if people kind of listening are wanting to know more, Matt's just mentioned about advancedchoice.org. If you just Google advanced choice documents UK, and there's also a really good website for by SLAM. There's a lot of information out there. Again, another question for Matt while we've got you. So this question is from Louise. Will the detention rules regarding tribunals, etc., apply to forensic units, in brackets, when serious crime has been committed, as well as mental health wards?
So there is quite a complicated table about exactly what the frequency of referral to tribunals is, and it depends not so much on the ward you're in, but the section that you're under. So the referral I set out, 3 months, 6 months, and every 12 months, is for people who are under Section 3, which would be non-criminal justice patients. For people who are under Section 37, there'll be a referral period of, they'll be auto-referred once every year. So if it hasn't been considered within 12 months, there'll be an auto-referral to the tribunal. And there are various permutations of this about whether you're under CTOs or guardianship or Section 41, all of which is quite complicated to set out, but this will be set out in the Code of Practice. And I think there is a table that was published alongside with some of the explanatory notes that sets out exactly how this applies to people in the different sections.
Brilliant. We've got a reflection from Laura in the Q&A. So not a question, but an observation for awareness. NHS England are already hearing reports of funding disputes between health and social care regarding supervised discharges. So that was the first part of the new act that I think it came online on the 18th. So again, this is very, very new, very, very live. With one local authority refusing to provide any funding for this currently, ICBs are experiencing this issue. ICBs experiencing this issue are escalating to their legal teams. Reiteration that these patients are subject to Section 117 provision and joint NHS local authority responsibility would be helpful. So again, all of these changes are taking place under extreme funding challenges. And yeah, there aren't, there aren't easy resolutions to that. So I don't know if you've got a kind of reflection back on that, Matt. You may not, so that's okay.
I don't know the details of the individual case, and I can't comment on that in any case. But I think, yeah, we are clarifying some of the deeming rules and things under section 117. Again, the code of practice will go through a lot of this and we'll be setting it out. Because this has come in relatively early, we'll have time to reflect on that and include anything we need to in the code of practice before it's published.
Brilliant. I'm gonna bring in I think it's a comment. I'll read it out from Mary. Mary Patel from the Triangle of Care at Carers Trust. And she says, thank you to all the presenters. I would welcome the panel's views on how any of our panelists, please feel free to, if you want to jump in, if you can make sure you slide so you'll appear on the screen and unmute yourself. Would welcome the panel's views on how the code of practice can provide clearer guidance to professionals on the rights of unpaid carers and families, which are wide-ranging and often complex. For example, the introduction of the nominated person will inevitably intersect with a carer's right to be involved in discharge planning, and these individuals may differ and hold conflicting views. It is essential that professionals receive clear guidance so that the move to greater community provision doesn't lead to additional risk and responsibility being shifted onto families. So just while I'm waiting for anybody else who's going to join us on the screen, when we were doing the review, and one of the things that I was responsible for was chairing a lived experience advisory group, which were 12 phenomenal individuals. I cannot do a session on the Mental Health Act reforms without mentioning them. They rode us incredibly hard, and they were involved in all of the aspects of the reforms. And in particular, they were heavily involved in creating the new principles, so I thank them for that. One of the things that was quite a difficult tension to manage and to sit with is the balance has to sit with the patient. And on that point around the nominated person, somebody will now be entitled to appoint somebody that might not be the person that's actually caring for them when they are, not in hospital. So I think that's a really good point to bring out there. But yeah, Matthew, and I think we've still got Nisa on board. Thoughts on how the code of practice can help?
So we absolutely want to reflect the views of carers as well as service users in the code of practice. I think, as Sam outlined, we'll be doing quite extensive engagement as we develop it, and we'll have a specific patient and carer reference group that we'll be working with to kind of test parts of chapters, specific kind of guidance that we want in there. Specifically, I think relating to the point you made about a nominated person, there will be guidance around this as well, and in particular for under 18s, where there is an interaction between the nominated person and parental responsibility. We'll be setting that out in quite a bit of detail because there was a lot of debate around that as we went through Parliament. I think we'll reflect as well at that point on what the status of informal caring should be in that part as well, because it's really clear that kind of there is a potential tension there if you've got a nominated person advocating for someone to be discharged, but they're not the person that would be caring for them once discharged. We are definitely aware of that risk, and we'll be working through exactly what the guidance should be in those situations.
Yeah, and I think there's something that is slightly uncomfortable because we're going to be in the grey for a while. And I think that the not knowing exactly is really important, and that will require not just kind of working collaboration, but I think also people that are gonna elect to be involved in supporting these reforms through to be able to kind of support each other almost psychologically, because it is a shift. And it is this shift in trying to make sure that everybody's kept safe, but also that we understand that being detained under the Mental Health Act is one of the most draconian acts that the state can take for somebody that, on the whole, has not committed a crime. So again, this is an incredibly complex piece of law. Um, and we are trying to modernize and make sure that it is healthcare that really protects people's dignity. Nisa, you might want to jump in. You're here. Any comments? I've got another question as well. But Nisa, any thoughts on anything that's been said so far? You're on mute.
Sorry.
No
I'm
worries.
definitely in agreement with everything that has been mentioned. And I think for me, the most pressing thing is just the recognition of how all hands are needed on deck here, and also thinking about the wider plan for how the code of practice is shared. I think once that has been produced, what will it look like to ensure that practice is changed? And what would it look like to involve the community, for example, having community conversations? And I'm not saying this is the responsibility of the DHSC, but collaborating with other partners in the sector to ensure that everybody knows about the change. Because I think it's interesting working in community sometimes and recognizing that while we think there is this urgent need in the Mental Health Act, some people don't even understand the previous Mental Health Act that was there. So I think just ensuring that we're all on the same page, carers and people who themselves are experiencing the illness would be important.
And I think whilst we're kind of on this, so there's a question that we had from James, that kind of taps into some of what you've just been saying there. So he asked, has there been consideration of or any monitoring mitigation planned regarding risks that supervised discharge will disproportionately be applied to Black patients in the same way that CTOs are? CTOs are disproportionately, he said here, 8 times more likely to happen to a person of a Black ethnicity than a white ethnicity. Huge overrepresentation. So I guess kind of opening that up to Matt, but also Nisa, your thoughts on this as well.
I can go first. This is a concern that's been raised, and it's something that we will closely monitor. The initial application of supervised discharge is very limited, so the need for it came about because of what was known as the judgment, which was that we weren't allowed to conditionally discharge people with deprivation of liberty. And there was a specific workaround that was being used using Section 17 leave, which wasn't a sustainable solution. So as this has been introduced, it is primarily to address that very small situation that at the moment only applies to around about 20 people in the country. So that's kind of the initial use. There is potentially wider use of this, and it's something that we'll be closely monitoring and looking at. And we will definitely monitor where we can kind of any racial inequalities that arise in the use of that. But given the small numbers in the initial cohort that this applies to, it'd be very difficult to kind of make any strong judgment on that at this stage.
I think one of the things that is certainly on my mind is that there is a greater understanding I feel of the unintended consequences of some of the aspects of the reforms, perhaps in a way that there wasn't in 2007. Those changes. So again, everything, when it gets tested by reality, that's when you really see how it works. And again, we need to work together as a community. And yeah, I'm very thankful to everyone that's on the webinar. I'm going to hand over to Dania for kind of just some final reflections, as we have about 90 seconds left of the webinar. No pressure.
No pressure at all. I'm not sure how to wrap that up really, but I think when we're thinking about everything that we've heard today, I really just want to come back to how important the principles are within this about the choice and the autonomy, but also, you know, that what the intention is. It's about reducing discrimination. It's about reducing the disproportionate impact that the mental health has had over the years on Black people, especially. And the final question that came from James really does fit in well with that. I would just like to thank all our speakers today. We are very short on time, but we did, so we couldn't bring one final person in, unfortunately, but hopefully we can follow this up with another event shortly. But thank you to all of our speakers. Thank you to everyone who has attended. We'll follow up with any links and documents that have been mentioned today and share those with you. Thank you so much.
Thank you.